So what I wanted to open up before we actually get to the panel discussions was just to give you the state of the state and really speak to cardiovascular health disparities in the state of Louisiana, review the scope and drivers and solutions. And I emphasize that because our purpose here today is to focus on the solution. But we have to know what the problem and challenges are. So one thing I want us to be aware of is that when it comes to cardiovascular disease, we are currently, will continue to be a global health crisis. And as you can see in this slide, in the United States, the average death rate per 100,000 individuals is 224 compared to the global rate of 235. So we're not really far behind the global rate. In terms of people who are dying with cardiovascular disease, there's a death every 34 seconds. On average, someone dies in the US from a stroke every 3 minutes and 11 seconds. And the rate of death from strokes in the United States is on the rise. So I don't know about you, but I find it very striking that that's the reality that we live in. But it's something that we really do need to be aware of in order to make sure that we can take the health of Louisiana in the right direction. So in terms of what's happening in Louisiana, this slide is showing you the top 5 leading causes of death. The orange bar represents the United States. The darker orange or reddish bar represents Louisiana. And these are the age-adjusted death rates. And as you can see, heart disease is the #1 killer in Louisiana. And again, for most of these, the rate of death from these conditions in Louisiana exceeds the US average. Where you live matters. So what this slide is showing is cardiovascular disease in Louisiana compared to the other 50 states. So on the left side is heart disease. The darker the orange or red, the higher the rates of disease in those states. And you can see Louisiana ranks 5th out of 50. In terms of strokes on the right, the darker the greenish blue, the higher the rates. In Louisiana, we rank 4th compared to the rest of the United States. Now let's look at it by parish. Again, even within your state, where you live matters. So that north side of the state, where it's dark for heart disease, like in the Monroe area, that's a largely rural part of the state. If you look at the strokes, well, it's almost the whole state, is a dark state, which means that the prevalence of the number of people living in Louisiana with a stroke who have had a stroke is huge. And a lot of that has to do with us being a rural state, distance that people have from healthcare. Now let's think about women, because our third panel is talking about pregnancy disorders and related morbidity mortality. For women in the reproductive age of 20 to 44, this is showing by state. And Louisiana is a dark blue, meaning that our rates of death among that age group among women is higher than the US average. Thinking about the reproductive age, what are those pregnancy-related deaths? What's the cause of that in Louisiana? And as this slide is emphasizing, again, cardiovascular heart-related diseases, so that's cardiomyopathy, cardiovascular conditions, are among the leading causes of why women are dying within the first 12 months after pregnancy. So when we calculate the pregnancy, it's not death rates, it's not just about what happens at the time of birth, but the entire year that follows delivery is significant in terms of how we define pregnancy-related deaths. We have a huge problem in the state of Louisiana, and a lot of it is cardiovascular. You'll see literature that talks about accidental overdoses being the #1 reason in Louisiana. That actually speaks to mental health, so you've heard of postpartum depression and other things, but for today's sake, we're focusing on the cardiovascular side of the problem. So we've talked about geography, rural versus urban, where you live. There's also other factors that are associated with a higher risk of heart disease. And so the older you are, once you get past 65 and older, your rate goes up. Men have a higher rate of heart disease. No strong association by race in terms of heart disease, but your level of education makes a difference. So those who are less than high school have higher rates, and also your household income. So low-income family households tend to have higher rates of heart disease. You can see a similar pattern for stroke in Louisiana, where again, age is important, the gender differences are there, and now you start seeing a split in terms of the risk of race and how, the different prevalence rates amongst the different groups. I do want to note that our population data, if you ever see it, it often will show Black versus white. That's not to say that other groups do not have these conditions. It's just a matter of how much data is available. And in the state of Louisiana, those tend to be the two populations that are overrepresented in data. But again, education and income matters in terms of putting that risk for stroke in Louisiana. So then what are the contributing factors? The Louisiana Department of Health really speaks to that some risk factors are modifiable and some are unmodifiable. And the only thing that we have control over are those things that we can modify. So on the left of the slide, smoking, weight, sedentary lifestyle, blood pressure, and diabetes control, as well as cholesterol level controls. So often when you come to the doctor's office, that's what they're focused on because that's what you have control over. But in terms of those lifestyle risk factors that put you at risk for a lot of these chronic conditions, this is just another way of looking at the US and compared to Louisiana. And you can see across all of these categories of lifestyle factors, physical activity, obesity, diabetes, hypertension, and smoking, that the rates in Louisiana exceed the US average across all of these categories. And again, these are things that are considered modifiable. So one thing I want to do is pause to take note of something and some trends in the data that we've been showing for Louisiana, which is that 88% of what drives health outcomes is related to social issues, or what they call social drivers, defined by the World Health Organization as conditions in which people are born, grow, live, work, and age. And these are circumstances that are shaped by distribution of money, power, and resources. As you can see from this slide, whatever happens to you when you walk in a doctor's office or in the hospital, that's only 20% that's driving your health outcomes. And quite frankly, it's downstream of a whole bunch of other things that put you in a position to be sick in the first place. 50% of those things, socioeconomic factor and the physical environment, depends on the zip code in which you live. And then, as we mentioned earlier, there are those health behaviors that we can control, but they do actually contribute about 30% to our health outcomes. So we have to be aware of the complexity of why the state of Louisiana has the poorest health outcomes. I forgot to mention too, Louisiana is always 50th when it comes to the health rankings, and we only compete with Mississippi to be 49, but we've not really got past that in all of the last 30 years. I mean, that is significant. So we do need to address this. It's important to pause also to take a note that there are certain populations who are disproportionately at risk, and that's what the data that I just reviewed with you is showing. So there are select ethnic groups who have a higher prevalence of disease, women, and especially women of color, and those, as I mentioned earlier, all populations live in rural parts of the state. And one thing I see missing here is those who have what they call limited English proficiency. It's not their first language. And low income. Those are the groups that are disproportionately affected. Those groups tend to have lower access to care in terms of insurance coverage, fewer referrals to specialty services, and long wait time, all of which reduce access to the care that they need for health prevention as well as therapeutic cardiovascular care. This adds up. These barriers contribute to undertreatment and worse outcomes after heart attacks, cardiac arrest, and other cardiac events. And so it's important for us to focus on how to promote access to care for all populations to improve everyone's opportunity to be as healthy as possible.
Good.
So there are compounding factors, and so when we think about solutions, you have to understand the different levels of what affects outcomes. And so this slide is really getting us to think about their system level issues, there's community level issues, and then there's patient level factors. All three of those things are equally important, and we have to think about the problem globally in order to come up with solutions. So on a system level, I know you've heard all the conversations about insurance coverage, restrictive policies, and things of that nature. It's real. It can restrict your access to care. In terms of patients, I mentioned language barriers, geographical isolation, like rural populations. Some folks don't have transportation to get to the doctor's office. And then, truth be told, education level can impact what we call health literacy, how well you understand and take care of your conditions. All these things can limit your ability to adhere to the therapeutic plan. I already mentioned before the role of social determinants, and so I won't repeat that here, but suffice it to say that they hinder a patient's ability to engage with healthcare systems. And there are certain populations, women especially, and women from minority backgrounds who tend to face extra barriers, which will be discussed at our third panel today. But as we said, the American Heart Association is in town, and you have a bunch of doctors that are downtown going to the convention as we speak to talk about the latest and greatest on guidelines. That organization and research related to those cardiologists have already proven what we need to do and where the evidence says we should focus. And there's two things: intense blood pressure control, as well as team-based care are the leading interventions that help to control or reduce the risk of heart disease. You've all heard about lowering your blood pressure systolic, that's that top number when you go to the doctor's office, to get it between 120 and 130. Well, now the American Heart Association, hot off the press, like a week or two ago, said, no, we need to focus to get it down under 120. So tighten up a little bit more. That's where we are now. They've also promoted having standard protocols to make sure that everyone that walks through the door, that we think about them the same in terms of what they may need to get their conditions under control. We're also to promote monitoring their blood pressure at home, because what happens at home is actually more valid than the reading in a doctor's office. We also have to think about those rural populations, people with transportation issues and other limitations, to diversify how we get that care. And so that's where telehealth, telemedicine videos, all that stuff that you guys have heard about during the COVID pandemic, as well as outreach. And it's already been proven that these types of interventions maximally impact those higher risk groups that we talked about earlier. Something that's underappreciated is the power of partnering with the community to help. And community health workers is an example of such an intervention, where these are peer navigators that help with coaching and self-monitoring, helping you navigate the resources of the community. All of these things combined have been shown to reduce the rate of heart attack, stroke, heart failure, and cardiovascular death by up to 42%. So in terms of when we know all of that, then what's the framework we have to work with? Well, today's panels are designed to do a deep dive into what we know actually works. Multidisciplinary care teams with professionals of all different backgrounds. So that means it's not just a physician, it's nurse practitioner, pharmacists, and other folks around them. Active involvement of the community in order to foster trust and enhance participation. I think we saw a lot of that conversation around trust as relates to vaccines. Culturally tailoring and linguistically appropriate services are necessary to increase accessibility and adherence. And it never, ever fails that we have to pay attention to state and federal policy as it relates to our health benefits and access to care. And last but not least, we have to focus on training the next generation to understand the complexity of the problem so that in their delivery of care, they can tailor it to the patient that's sitting in front of them. So those two things I mentioned earlier that are important: team-based care. Again, we promote multidisciplinary care with social workers, community health workers, pharmacists, and care coordinators because they've been shown to improve patient support and care delivery. These types of interventions have also been shown to significantly reduce blood pressure by 7 millimeters, improving control rates up to 12%. And then those peer navigators are critically important to helping people navigate the system and connecting between the community and the health system to reduce disparities. Community engagement. It is important that the health system partner with trusted community partners. So you may have seen programs that are based in salons and the beauty shops, the health ministry for the local church. All those things are programs that boost trust, but they also boost sustainability because it's embedded in the community. We do have to be mindful of bilingual, multicultural staff, and that providing services in a person's language actually is going to improve access to care and better control. And for those of us who may not speak the language, we should know to use interpreter services because those are certified individuals who are taught how to translate between the doctor and the patient with your team. In terms of policy and professional training, we talk about insurance coverage, and I won't be political and go into it, but you see it a lot in the news that it is very much an issue for a lot of people. But improving insurance coverage improves access and therefore reduces disparities in heart disease. We also have to diversify the workforce, as I mentioned earlier, to address barriers. And then the policies that we have on the state and federal level do affect or better link the patients to their services, reduces hospitalizations, and also death rates in those high-risk groups that we talked about earlier. And then finally, in terms of professional training, as I mentioned earlier, we have to focus on teaching our physicians, our nursing students, and others around the role of social determinants and how addressing those effectively can improve care delivery and increase adoption of evidence-based practices. So with that, I'm going to pause. Not sure how much time I have left. Any time left over? Or I'm just at it, 45 minutes. Okay. So before we transition into our first panel, I just wanted to, if there was any comments from the audience or any questions, points of clarification you need before we transition, I wanted to give you a minute before we do that. Yes, ma'am.
I wait to have what you can
It was a big word.
That's a good question. That's a very good question because there are a lot of our colleagues who are not from Louisiana, but they always say once they came here, they gained about 10 to 20 pounds, and that's real. Your college students who are from out of state gain 10 to 20 pounds, and it is, our diet does play a role in it. That's a perfect example of needing to culturally tailor our advice on nutrition, right? So if I hear someone say, tell us from Louisiana, you need a low-salt diet, low-fat diet, then the first thing that comes to mind is our Cajun Creole food is not going to taste good. That's like telling me to eat gumbo made in Wyoming, Montana. Like, that's a no, right? But if I understand that that's the culture of Louisiana, and I want to help you with your nutrition and thinking how you can still have that flavorful food, but not have the same risk of heart disease and high blood pressure, that's an example of having to know how to culturally tailor the advice. I have to understand, how do you cook? What's your favorite food? What's your ingredients? Can I give you some suggestions of alternatives that may help it still taste good, but just not be as high in fat and sodium? That's the example of cultural tailoring. You can give 2 minutes. Any other questions? 2 minutes left. Yes, sir.
What's the number of real phenomena and position that you have when you're assessing whether
So the question is white coat hypertension a real phenomenon? So white coat hypertension is, have you ever, any of you, been to the doctor's office, your blood pressure is always high, but when you go home and you check it, it's normal. So it's like, no, coming into the hospital or the clinic is stressing you out and your pressure is high. So we always say, if someone's pressure, the first time you meet them is high at the doctor's office, you gotta get them to check it at home, because that's where we tend to be more relaxed. And that tends to be a more accurate reading. So that would be white coat hypertension if it's high in the office and normal at home. There's something called max hypertension, where you go to the doctor's office and it's normal all the time. But when you go home, it's actually high. Again, that home reading is more accurate. So it can go both ways, but it really speaks to the importance of knowing your numbers and checking the blood pressure at home.
Yes.
Yes, ma'am.
The difference between the different word that we got they have the electronic
Yeah. Yeah.
and then we have the regular
Manual.
okay. I know I can just take down from the manual to come up better than the electronic stuff, but obviously that's not I did it and then I said the battery to put the thing on and the machine stuff like that. So I'm like is that correct?
So, this is what I always tell my residents in clinic. These are doctors in training and chronic care. If they come to me with a high blood pressure reading, I know it was taken with the automatic machine. So my first question is, did you retake it with a manual? Not with the machine, did you retake it with a manual? Because the difference is we're listening with our ears to be able to tell where the pressure we're talking about the number is, as opposed to the machine. Now those machines can be pretty good, but doing it manually is considered the gold standard there, to do it that way. I should also mention that there was an issue with people using, even at your home cuff, using one that's on the arm versus your wrist. I always say use the one that goes on your arm because you need to have the cuff at the level of the heart. If you do use a wrist, which I really don't like, but if you do use the wrist cuff, you're supposed to keep the arm relaxed across the chest because that puts the cuff at the level of the heart. I discourage using that because that can be inaccurate as well.